Welcome back, everyone, to Part 14, the penultimate episode of our Breast Surgery Coding Masterclass Explainer. If you've been with us through the previous segments, you know we've already covered a massive amount of foundational coding. But today, we're transitioning from implants and capsules into the highly specific world of aesthetic, symmetrizing, and corrective procedures. We'll be taking a really close look at reshaping, reconstructing, and refining. Our goal today is to decode the complex clinical intent behind these procedures and see exactly how that translates into the CPT manual for professional auditors and coders. Let's get started. Here's our visual syllabus for today. We'll be moving through breast anatomy basics, mastopexy and breast lifts, reduction coding rules, augmentation and implants, nipple and areola reconstruction, and finally, revising reconstructed breasts. Section 1, Breast Anatomy Basics. We have to ground the codes before we start assigning them. All right, let's start by looking at the primary regions of the breast. You've got the circular body, which is the largest and most prominent part, made up of lobes and ducts, and that's superimposed by subcutaneous adipose tissue, or simply put, fat. Now, this entire structure rests right over the underlying pectoral muscle on the anterior thoracic wall. Understanding the spatial relationship is absolutely critical because when you're reading a surgeon's operative report, they're documenting the excision of tissue from very specific anatomical layers, and you need to know exactly where they are working. Now, running right through this whole region is a highly complex lymphatic network, which, as we know, filters fluid and fights infection. During sentinel node mapping, a radioactive dye actually tracks how cancer cells might spread from a primary tumor to that very first or sentinel lymph node. This pathophysiology, which can range anywhere from benign fibrocystic changes and cysts all the way to malignant tumors, is exactly what dictates the extent of the surgical intervention we end up coding. Section 2. Mastopexy and breast lifts, focusing on elevating the tissue. So a mastopexy corrects ptosis, basically sagging, by relocating that nipple areolar complex to a higher position and removing the excess skin below the nipple and above the lower breast crease. As coders, you've absolutely got to remember your WHCRA regulations here. Symmetrizing procedures on the contralateral normal breast post-mastectomy are federally mandated covered benefits. Because of this, you must always append your laterality modifiers, -RT for right, -LT for left, or -50 for a bilateral procedure. Here's where the op report details will literally make or break your code selection. You report CPT 19316 when the mastopexy is performed via an open approach. It's not straightforward. However, if your surgeon's documentation describes a minimally invasive lift, you absolutely cannot use 19316. Instead, you have to drop down to the unlisted procedure code for the breast, which is CPT 19499. Moving on to Section 3. Breast reduction coding rules and how to navigate those tricky bundling traps. Code 19318 is used for reduction mammoplasty to treat macromastia or symptomatic hypertrophy. But here is the critical documentation mandate for us as medical coders. To satisfy payer medical necessity and the really strict requirements of the Schnorr sliding scale, the operative report must explicitly record the resected tissue weight in grams per side. Without that specific gram weight, your claim is headed straight for a denial. No way around it. Listen closely, because this is a huge insider tip. Liposuction is strictly inherent to code 19318. So let's say a patient undergoes a bilateral symptomatic reduction. The surgeon resects 650 grams from the right breast and 620 grams from the left using an inferior pedicle transposition. You report 19318-50. You do not report the liposuction, the excision of skin, or the wound closure separately. It's all completely bundled into that primary procedure code. Section 4, Augmentation and Implants, where we focus on restoring volume. When you're dealing with CPT 19325 for breast augmentation, you really have to note the clinical differences between implant placements. Subglandular implants are placed above the chest wall muscle, while submuscular implants are tucked beneath it. These augmentations are typically done to treat hypoplasia or to ensure post-mastectomy symmetry on the contralateral side, brilliantly restoring both volume and shape. Okay, let's dive into a really important nuance. While 19325 covers the augmentation with a prosthetic implant, surgeons will sometimes use autologous fat transfer to further improve the contour and correct tissue defects. If fat grafting obtained by liposuction is performed alongside the implant, you report add-on codes 15771 or 15772. But here's the catch for auditors. You have to look for the precise CC documentation of the injected fat, not just the raw lipoaspirate. CPT 15771 covers the first 50 cc, and 15772 covers each additional 50 cc of injectate. Section 5. Nipple and areola reconstruction. We're talking complex grafting here. So the crucial point for CPT 19350 is understanding just how much surgical work is bundled into this one single code. It includes excising donor graft skin, often using local skin flap techniques like a skate flap or CV flap, repairing that donor site, and structuring the new nipple mount. Keep in mind, though, if the physician also performs 3D micropigmentation tattooing, you'd look to codes 11920 through 11922. Or if they create a custom Moulage impression mold for a personalized prosthesis, you'd report 19396. Those utilize separate code families entirely, so don't mix them up. Section 6. Revising reconstructed breasts. This is honestly the ultimate audit challenge. Listen, CPT 19380 is not just for minor tweaking. It requires substantial soft tissue excision or major reshaping, which makes it a really heavy target for audits. Let's say you have a 46-year-old post-mastectomy patient who requires an open revision. The surgeon readvances the inferior flat pole and injects 80 cc's of purified autologous fat into the superior pole. That is significant anatomical work. In that case, you'd report 19380-RT alongside 15771-RT and 15772-RT for the fat graft. Also, if an implant is exchanged during this revision, be on the lookout for the concurrent exchange code 19342. Now, right here is your ultimate bundling trap. You must never, ever report 1930-80 on the same breast alongside intermediate repairs, complex repairs, trunk liposuction, or primary revision codes like mastopexy, reduction, or open capsulotomy. The CPT guidelines are incredibly strict on this. All of these concurrent procedures are bundled straight into the heavy-lifting parenchymal revision work of 1930-80. Before we wrap up, I want to leave you with this scenario to think about. If a surgeon performs a breast reduction and the operative note details extensive liposuction to beautifully shape the contour, do you report that liposuction separately? Think back to our strict bundling rules we just discussed. Does the pursuit of aesthetic perfection override CPT inherent inclusion guidelines? Hold on to your answer, because we're gearing up for Part 15, the grand finale of our Masterclass Explainer series, where we will break down a massive coding quiz and dive into full comprehensive operative chart audits. You won't want to miss it. See you there.